I want to welcome you to the Therapist Hour, and I'm so glad to have you here. Dr. Merriman, your work as a poet, as a dentist is just so welcomed by us, and we're looking forward to learning more about sleep.
Kristin, thank you so much for inviting me. It is absolutely my honor and my pleasure to be here, and it pushes forward something that is very important to me, which is sleep. To me, sleep is something that is very obviously a part of our health. It's important for our physical health, our emotional health, our spiritual health. But the reason why I do this is because without sleep, I feel we are disconnected from our soul. And when that happens, we cannot exist in the way, in the beauty that we are intended to. So coming from the perspective of a poet, I, being a dentist, have now trained as a dental sleep medicine professional, and I'll go over all the details. So the clinical people understand it, the psychologists who are doing clinical work understand it. And if there is a patient that hears our conversation, someone who is disturbed in their sleep, in their emotional health, they can start to tie things together and have a path that will lead them to the help that they may need for their sleep. So we're going to put this all together, but for me, sleep is the path to our soul.
That's beautiful. And I so agree with you.
What I have today is I have some pearls that I'd like to bring to you. And at the end of this presentation, I want to make sure that we have a necklace that we can wear. And it has all the dots connected as to what the heck is a dentist doing on Therapist Hour? And why is she speaking about sleep? You know, what is it? Are there not enough fillings to do? Are there not enough, oral cancer screenings to do? But dental sleep medicine is something that is a part of sleep medicine. Our objectives today is, why is knowing about sleep disorders important for you if you treat or know someone who suffered from ACEs, trauma, or has a psychiatric disorder? What is dental sleep medicine and oral appliance therapy? And why is there a need for a dental sleep medicine provider on a multidisciplinary, integrative care, trauma-informed, patient-centered care team? Now, that's a lot of words, but if we don't take all of those factors into account, integrative to me means taking into account that the patient's mind and body are connected. The disease processes of the mind and the body impact both of them. Trauma-informed, we unfortunately are living in a society that is heavily traumatized from one factor or another. Patient-centered, because if we're not looking at a patient from a holistic 360, the mind, the body, and the soul, we are missing things. And in the care that we are providing them, we are leaving things undone that cause issues with the quality of care, with the totality of care. And in that, their experience of recovery and healing is incomplete. To start with, I want to briefly go over sleep architecture, very briefly. So when it comes to sleep, we have the stage of being awake, which hopefully all of us are right now. Then sleep is broken down into non-REM and REM sleep. So non-REM is non-rapid eye movement sleep. This is the bulk of our sleep cycle, and it's approximately 80% of the night. There are 4 stages of non-REM sleep. It goes back and forth. There was a time recently where from 4 stages it went to 3, but let's take non-REM as having 4 stages. And then comes REM sleep, which is approximately 20% of the night. REM sleep is normally experienced 3 to 5 times. All these stages are going to be experienced 3 to 5 times a night, or about every 90 minutes. When it comes to REM sleep, the first episode of REM sleep is going to be the shortest, but as we sleep and we go through the night, the REM sleep period of the sleep cycle starts to expand and increase. And there are some implications of this, because if a person is not getting enough REM sleep, then all the benefits of REM sleep are not going to be experienced by the patient. This is the same for every stage. Every stage of sleep has a different purpose in addition to having the universal benefits of sleep. So during stage 1, 2, 3, and 4 of non-REM sleep, there are specific neurochemical changes happening. There are specific functions of sleep that are being performed by our brain and our body specific to those stages. And the same is for REM sleep. Now, one thing I want to point out here, which we're going to tie together at the end of our conversation today, is that in the entire 24 hours of the day, there is only one time when we do not have the secretion of noradrenaline, and that is a stress-producing hormone. That is during the REM sleep. If you've been catching the latest information about the research and studies of REM sleep, one of the things that comes to mind, which is very important and interesting for your group, since you're all into the healing of your patients, your clients, of traumas, of psychiatric disorders, that time, REM sleep, is now being looked at as overnight therapy. When we don't have noradrenaline flushing through, that is very possibly a stage when we have less of that stress, and REM sleep is showing to be that time of the night of our sleep cycles when the emotional component that we attach to our experiences is being washed away. I may be really simplifying, and I am simplifying something which is so big of a concept. But let's think about the fact that if we're not getting good sleep, and if we're waking up early, for example, in depression, one of the common things that a patient may complain about is that I get up at 2 in the morning, 3 in the morning, and I just can't go back to sleep. That's a ding ding. The patient has sleep issues. But if a patient has not been diagnosed with depression, they may even be having a conversation with a friend or someone who is a non-professional saying, like, I get up. But the more of us that understand early morning awakening is one of the signs of possible depression, then we can start to really, again, tie things together. So if you're getting up early, and let's go back to what I said, and I'm going to actually pull up the next slide. So here is a very simple slide. Sleep onset is here, as I mentioned before. Earlier in the night, as we start to go through the cycles of sleep, our REM cycle is the shortest of the night. But if you notice, it's in the purple, it starts to get more significant as we go along. So if you woke up at 2 in the morning, 3 in the morning, and you were unable to go back to sleep, you really are not getting the most out of your REM sleep cycles, because your first few cycles were the shortest. And now you're being robbed of your later early morning sleep or later morning sleep. And you're not getting those full REM cycles. So those overnight therapy sessions are very short for you. And that can make a big difference in how you wake up and how you feel. Again, I'm oversimplifying the process, but I'm not a neuroscientist. Here's a good place for me to share with you what is my perspective. I am a survivor and now thriving after treatment of attachment trauma, of adverse childhood experiences, and a very complex childhood trauma. I had no understanding of how much of that trauma had impacted me. When I went in for Davenlou's ISTDP, I didn't know who Davenlou was. I didn't know what attachment trauma was. I didn't know what attachment was. I didn't know what ACEs were. No clue whatsoever. I went in for relational issues. I was having trouble in my personal relationships, and I was ruminating all the time. But also what was happening was that I was not sleeping well. It may have been, looking back, almost a decade of poor sleep. Getting up, how do I know all these things? I know all these things because I have experienced them. I would get up at 2, 3, and I did not know what good sleep hygiene was. I was a practicing dentist. I've been practicing for 25 years, but I was unaware. And that's why I come and I talk, so that I can share these things that right now seem so common sense to me. But even as a professional, I knew very little, if anything, about sleep. So that is my perspective. While I was still in therapy, things, again, unconsciously were connecting. And I said, I want to know more about sleep. So let me tell you a little bit about what my background is. This is my office. I practice in Westfield, New Jersey. Sleep medicine is the identification and treatment of sleep disorders. And dental sleep medicine is an area of dental practice that focuses on the use of medical device or oral appliance therapy to treat sleep disordered breathing, which includes snoring and obstructive sleep apnea. My background is getting a degree of general dentistry, from New York University in New York. I then did 2 years of a general practice residency under Dr. James Shuba in Long Island at the Long Island Jewish Medical Center. Practiced for many years as a general dentist. I still do. But then as I got into sleep, I realized that I wanted to commit very fully. So dental sleep medicine is an entity that is, how do I explain it? So oral appliance therapy is the mode with which we treat patients. But the science of sleep is what we use. The understanding of sleep disorders, how do they appear as comorbid conditions to a patient's general health, physical health, and their mental and emotional health. So even though we are using oral appliance therapy and we are trained into the oral cavity, the head and neck area, but it really is a distinct specialty, which is on its way to being recognized as so. And what I ended up doing was I did the whole process to become certified as a dental sleep professional. So I am certified through two different boards of sleep. One is the American Academy of Sleep Medicine, and the other is the American Academy of Craniofacial Sleep Medicine. So what are the conditions that a dental sleep medicine professional, I'm going to refer to it as DSM from here so that we can just keep it simple, but what is it that we are treating? So we're treating obstructive sleep apnea, we're treating primary snoring, and we're treating at times a combination of obstructive and central sleep apnea. There are many comorbid sleep disorders may exist alongside obstructive sleep apnea that will be then treated by a board certified sleep physician. But this is all a very collaborative process. And so insomnia, restless leg syndrome, these are conditions that are treated concurrently with obstructive sleep apnea. So let's talk about psychiatric disorders. Pretty much every single psychiatric disorder that is being recognized and treated has a sleep disturbance component to it. The symptoms of the sleep disorder and the symptoms of the psychiatric condition may very well overlap. And that's why I'm here today, because there is a bidirectional relationship between sleep disturbances and psychiatric symptoms. And for you to be able to optimize your treatment outcome, it is imperative that you recognize and help your clients get treatment for the sleep disorders they may be suffering from. I think this is a good place also to distinguish between lack of sleep due to circumstances, poor sleep hygiene, poor opportunity of getting sleep, and sleep disorders. Those are two different issues that do cause sleep deprivation, and they will mimic the symptoms of sleep deprivation. But once again, this is a full investigation to see, are your clients sleep deprived because of their emotional burdens, or are your patients sleep deprived because they're so overwhelmed with their life right now that they cannot focus and prioritize sleep? And that's where I believe you have such a front seat to their issues with sleep when you're able to focus them on it. There is a significant need that has been identified for psychiatric providers to train in the evaluation and management of comorbid sleep disorders in patients with psychiatric conditions. And once again, there are many psychiatrists that have gone on to sleep fellowships and are now board certified sleep specialists. And there's a resource at the end of today's presentation that I would urge you to have as part. It's a book that just came out, I believe, this year. It's called Management of Sleep Disorders in Psychiatry, and I have a picture coming up. So there are psychiatrists that go on to become sleep specialists, but if that's not the level of commitment that you're looking to make, and you have other focuses with your patient care, then no matter what your modality is, whether it's Davenlou's ISTDP, whether it's cognitive behavior therapy, whatever the case may be, sleep is a part of the history, a part of management that is critically important for the care that you provide to your clients and patients. I took depressive disorders as an example because it is so common. It's the most prevalent mood disorder. It affects 8 to 17% of the global population. And just in America, in the US, there's 20 million people who experience a major depressive episode a year. Think of that number. You know that number is probably not even as accurate as real life is, because you all have a waiting list of people trying to get in to see you. The pandemic has not done us any favors when it comes to our emotional health, when it comes to our mental health. If we weren't suffering before, the pandemic has brought suffering. If we weren't aware of our suffering, the pandemic has pushed us with the harsh conditions, with the isolation, with the loneliness that it's brought, to dig deep, and everything is bubbling up for many people. So the 20 million experiencing a major depressive episode, I think, is probably a little low. Now, 90% of this very large population reports sleep disturbances. This is a significant number. This is a significant source of information that we really have to take seriously. I suffered for so many years with sleep disturbances. Had someone said to me, "Hey, you're not sleeping well, maybe you're depressed," who knows? My suffering would have been less. Who knows that I would have sought help earlier? There's no way to know, but maybe. With a sleep disorder and depression, we have these factors to deal with: increased depression severity, poor response to treatment, greater risk of relapse, higher incidences of thoughts of death by suicide. This is serious stuff. Depression on its own is bad enough. Depression and not being able to find relief through sleep, not being able to get the benefits of sleep, the physical benefits, the psychological benefits to the brain, to the body, to feel rested and refreshed, for our cognition to be right on. If we're depressed, we're suffering from a psychiatric disorder, we're already not fully present. We're suffering, and lack of sleep, day after day, waking up with sleep deprivation, is taking us to the edge. I can't even remember being able to focus well in the work that therapy is when I did not have a good night's sleep. So even inside a session, when I am there, I'm not fully there without good sleep. Primary sleep disorders include OSA, restless leg syndrome, and circadian rhythm disorders. They frequently coexist with depression. These sleep disorders can mimic or worsen depressive symptoms. And as I've been saying, the optimal recognition and treatment of sleep apnea can improve depression outcomes. Now, here comes the medications. If a patient or a client is on antidepressant medications, they have their own impact on sleep, on the sleep cycles. I pulled up a few things that I just wanted to share with you is that evidence shows that when a patient who is suffering from depression is treated for their sleep disorders, they actually have a lower rate of relapse. The converse of that is also true. So if the sleep condition of someone who is suffering from depression is not treated, even after depression is treated, their chances for a relapse are higher. Adverse childhood experiences. We now know that ACEs have a long-term impact on our health all the way to adulthood. That is a science. This is not a hypothesis. This is what Nadine Burke-Harris's TED Talk. If you haven't watched it, I would highly recommend watching that, in which she calls for action as a pediatrician that was seeing so much of the impact of trauma on childhood, but brought great attention to ACEs. Very small print here, but I threw that slide in. These are the 10 questions that give an individual their ACE score. So the higher the ACE score, the higher the incidence of conditions that are seen as some of the highest causes for death in the US. So the higher the ACE score, the higher, the wider the experience of adverse childhood experiences, the higher the chance of those medical conditions. How common are ACEs? I'm telling you things that you know way better than I do. This is what your bread and butter is. But let's just look at these numbers. How common are ACEs? A 0% or a 0 score is shown to exist for about 38%. If someone has one ACE score, they say yes to one of those questions, they're in the 24%. 2, 13%, 3, 9%, and 4 or more is 16% of our population. That is millions of individuals. There are many sleep disorders. What I treat as a dental sleep professional are marked in red. And I'm reiterating that when it comes to dental sleep medicine, we are treating obstructive sleep apnea. Out of sleep disorders, you can see that sleep apnea is a very, very large amount. And if you add in this green part of the pie, that's chronic or severe insomnia. These are the bulk of sleep disorders. And so when you're looking at dental sleep medicine, you start to understand that we're treating a big chunk of the sleep disorders that your clients are facing. What is obstructive sleep apnea? It's sleep disordered breathing, and it is caused by the repetitive collapse of the upper airway. There are many reasons for a patient to get or to suffer from sleep apnea, but the symptoms are going to be the same. What is COMISA? This is a term that I started to recognize. It's a condition that I started to recognize when I started to see patients as a dental sleep professional. They'd come in, I would treat them for sleep apnea, but they'd still have complaints of daytime sleepiness, exhaustion. So I was wondering, what is going on? And that's when I started to think, okay, there's something else that's not getting resolved. And that's what spiked the interest of comorbid insomnia and obstructive sleep apnea. Coming back to psychiatric patients, 1/3 of psychiatric patients are going to be suffering from breathing related sleep disorders in their lifetime. The complication and the complexity here is that they share risk factors, symptoms, the disease course, and the outcomes. Very often, a patient will not know they have sleep apnea, just like they sometimes are not aware, many times, they're not aware that they have depression. They're not feeling totally right. They're not feeling their best, but there's this grayness, there's this cloudiness where it's not like, boom, I know what's wrong with me. If you cut your hand, you've got a wound there, it's bleeding. All of a sudden, our brain recognizes there's an injury, there's a traumatic injury that is physical in nature. But at that point, we're alerted to it. We seek treatment. We get to the end point of getting relief. When it comes to sleep disorders, when it comes to depression and psychiatric disorders, because of their complexity and because of their overlap, and it may also be because of our reluctance to accept or recognize, again, due to the stigma that has traditionally been there. We don't want to admit to ourselves that there may be something wrong with our emotional health because, oh my God, that's just not cool. So there is this additional slowness for us to get help for these conditions. And because the process is taking its own time to become evident, this becomes an issue. So the process, you have a client, a patient, you're taking a sleep history. At that point, the diagnosis for a sleep disorder would be with a board certified sleep specialist. Sleep apnea is dependent on being diagnosed objectively through a sleep study, which could be a hospital study, or it could be a home test. And other sleep disorders would be on the basis of a consultation with this board certified sleep specialist. Dental sleep professionals are referred patients with a medical prescription to be treated. So that is the flow chart of what happens if you suspect your patients have a sleep disorder. We're looking at a very simplistic blocked airway. When you're sleeping, your tongue is falling back, and that is blocking the upper airway right over here. Now, once again, this is not the only reason why the upper airway collapses. It's a lot more complicated, and there are other reasons as well. But this is a diagrammatic view of a large portion of what obstructive sleep apnea presents as. 90% of sleep apnea is undiagnosed, and that comes out to about 36 million people. How many of those are coming into your offices is a higher proportion than someone who is not suffering from a psychiatric disorder. what are the signs? What are the things that you can ask a person when it comes to, if they're saying, well, we have poor sleep, if they admit to having poor sleep, how would you know that it may possibly be sleep apnea? Well, snoring is a big indicator, daytime sleepiness, obesity, and patients who have hypertension that requires 2 medications or more, they all have much higher levels of being diagnosed or suffering from obstructive sleep apnea than an individual that does not show these signs and symptoms. CPAP, or continuous positive airway pressure, is the gold standard for treatment of obstructive sleep apnea. But this scene over here is not exactly how everybody experiences the CPAP treatment. If you can tolerate it and you're able to, and your bed partner tolerates it, then that is great. However, a lot of times CPAP does not work for individuals because they're just unable to tolerate it. They could be claustrophobic, and that's where a history of trauma or, people who are suffering from post-traumatic stress, they do show a lower ability to tolerate CPAP. So 40 to 60% of non-compliance, depending on, which study you're reading, but on a general analysis, you could say 1 out of 2 people is having a hard time tolerating the CPAP apparatus. And that's where dental sleep medicine would come in. I must let you know that for mild to moderate, the oral appliance therapy has been a therapeutic treatment considered to be the first line of treatment as per the guidelines of the American Academy of Sleep Medicine. If a patient has severe sleep apnea, which is 30 incidences of apnea or hypopnea per hour, and they're unable to tolerate CPAP, very likely they're going to discontinue and get no treatment. So in that case, oral appliance therapy is the treatment that is recommended. Oral appliances are custom made. They are medical devices that we monitor a patient for over a period of time. So there is a titration process which we instruct the patient, educate the patient, support the patient. And once the patient's symptoms of sleep apnea are relieved or eliminated, then we actually will send them back to our referring doctor to have a sleep test with the appliance in to look at the objective relief that the patient got, in addition to the subjective symptoms being treated. So many a times when snoring, daytime fatigue, drowsiness, which is a great source of scare for the highways, are treated, patients' quality of life starts to improve. And once we get the sleep study, we can also see how the apnea hypopnea index, their oxygen levels, and many other physical markers that the sleep physician is following are improving. We do not make sleep appliances. This science is not of, hey, doc, I'm snoring, can you make me an appliance? No, we actually will make an appliance upon receiving a medical prescription. And even if a patient is snoring, I'm not going to be making them an appliance without ruling out sleep apnea. So in addition to treating the patient for sleep apnea, what I have recognized that this is a terrific opportunity for us as dental sleep professionals, sleep medicine professionals, to take a history. We're already taking a medical history. In that medical history, when we see things like conditions like fibromyalgia, depression, symptoms of insomnia, symptoms of immune deficiency, cardiovascular disease, metabolic disorder, diabetes, cancer, we're now recognizing that those are also they occur at a much higher level for individuals who are ACEs survivors. So connecting those, this referral pattern is bidirectional. So I may have a patient that once I'm taking their medical information, I'm going through their history, I'm creating a relationship, I'm in a very good place to say, tell me a little bit about your childhood. And depending on how open they may be, start that discussion and find out. I always ask my patients about their childhood. After that's like my middle tier, I'll bring that up. Depression, anxiety. The first question I ask is, who's your therapist? Do you have a therapist? Just the other day, I had a patient who came in who's been on Zoloft for 8 years through a prescription from their primary care. And, guiding a patient to consider therapy when it may not have been brought up before, I feel is one of the advantages of integrative care. So these patients may not have even shown up at your offices, and they will come to you through a practitioner like myself that recognizes the whole picture and sees those signs of, oh, let's connect these dots. And there is an opportunity for dental sleep medicine to be referring patients back or to you. There is a whole screening protocol which is detailed, and that's part of what we do. But I picked these 4 or 5 questions in case you decide that you want to go a little bit deeper. So, is the patient complaining of daytime sleepiness? These are some key questions. Does the patient snore? Even if you ask these and don't go into the remaining 3 questions, well, obesity, you can see that, right? You don't even have to ask that question. You are onto something to then further, dig a little deeper. Some of the symptoms that you would have for sleep apnea are a patient's bed partner witnessing a gasping or a choking episode, snoring, excessive sleepiness not explained by the fact that they didn't sleep well a few nights in a row. When they wake up, non-refreshing sleep, not being able to sleep. Sleep fragmentation is a very distinguishing feature of sleep apnea. The patient may not wake up in a way that they're aware of waking up, but their brain is waking up, and that causes the sleep fragmentation. Going to the bathroom multiple times. The patient thinks they're waking up because they have to go to the bathroom, but in reality, the patient woke up because they had an episode of apnea, and then they just connected it to having to urinate. Decreased concentration, memory loss, decreased libido, and irritability. Mood disorder, mood changes, irritability is a very common factor for patients who are suffering from obstructive sleep apnea. Headaches is another common presentation where the patient may not have connected their condition to sleep apnea, but they wake up and they have a headache and it's constant. Sleep medicine under one roof. Wouldn't it be just fantastic, Kristin, if I had an office in your building and you had, a sleep lab there, and you had a pulmonologist, that would be perfection. And all we would need to do is walk from one room to another. But in the event that that's not possible for everybody, the efforts that I am making are so that we understand how these conditions are connected and how treating one without treating the other is not going to give the relief that our patients are looking for. And so we have our potpourri of specialists that we know, and then we may not be able to just walk across the hall, but we can pick up a phone and say, hey, I have a patient, I'm treating them for depression, I'm treating them for this psychiatric disorder. They also are complaining about, waking up unrefreshed and they're snoring. And I thought, maybe there might be something there. The resources that I was telling you about, the management of sleep disorders in psychiatry, this is a must-have for anybody who's treating a patient for psychiatric disorders, depression, insomnia, restless leg syndrome, every single detailed implications of sleep deprivation and sleep disorders and how they are connected and complex and what to do. It is excellent, excellent. Why We Sleep, I'm sure you've heard of this book. It is perfect for lay people, perfect for professional. Matt Walker, one of the most charismatic sleep ambassadors we have, has done so much to put sleep on the map, discusses actually, and very interested in the REM sleep cycle as that overnight therapy, tremendous asset to sleep. I wrote an article last year connecting ACEs, integrative medicine, and the mind-body connection and how dental sleep medicine plays a part. This is very, very new in dental sleep medicine. TMJ disorder specialists and people who are doing sleep medicine and TMJ are very familiar with their patients having chronic pain, depression. So we as dentists have seen this all along. And my goal is to keep moving this forward. Again, Kristin, thank you for this opportunity, but for us to connect it. And what came out very recently, Kristin, feel free to forward that paper that I sent you this weekend. The American Academy of Sleep Medicine has just released a position statement, and sleep is essential to health. It is, again, a wonderful resource to give your clients, your patients, your colleagues. Sleep 2030 is a movement that is in place right now. Sleep is a big part of that movement. The future is bright because it is about collaboration. There is no way for us to stay in our specialties and our isolation. We must reach out and see how these dots connect. And then to serve our patients to the best of our abilities, we must understand the mind-body connection. Kristin, you work so closely with Dr. Alan Abbas. I mean, the work that he is doing to empirically show this connection for those who want the research data, who don't want to take the word of poets, and those who have experienced the disconnect between the body, mind, and the spirit. His work is phenomenal, and he's one of many now that are showing how the conditions that affect our mind make a way in our body and the opposite way as well. This is my personal foundational way that I found success in therapy, in life, and I continue to focus on the fact that the pillars of health, exercise, nutrition, stress management, hydration, they are critical, but they stand on a foundation for me. And what I believe the future holds is that the foundation is love. It is relational health. It is love for ourselves, which then propels us to love others. Sleep and mental and emotional health are the next foundation, critically important. We cannot live without sleep, but I believe we cannot live without love. And with love, we're motivated to be healthy as well. I'm going to end again with a poem. Haunted. There are no promises to be made for the times that have not yet unfolded. So sleep, my love. Thank you.
Thank you, Dr. Merriman. That is so beautiful. I'm so glad that you brought up love, because all the research we are doing just brings us back to what we've always known.
Yes.
And you know, fortunately for the poets that go back centuries, right? We've been taught how important it is to first love ourselves in order to love others. And here you are today, and you're just reminding us of that importance. And you know, taking care of our sleep is taking care of our souls. And you are helping us understand how we can do that in a loving way. I'm wondering, can you just say briefly, like for anyone who's struggling with sleep, what is your recommendation in terms of them getting help, but also what they can do today, like this very evening after watching this video? How can they take care of their sleep?
If you're struggling with sleep, let me talk to you directly. You may not have a sleep disorder. You may, but start here. Start with the commitment to prioritize sleep, because there are a million distractions and cultural understandings that we have absorbed. We'll sleep when we're dead. Yeah, you'll sleep when you're dead, and you're going to die earlier. You're going to die, quickly, and you're going to be sicker. So there's a lot of pressure for us not to sleep. It's cool not to sleep. It's cool to overwork. So just know that this is going to be an attitude change. It's going to take time. But today, if you could just say, my sleep is critically important for me to be able to survive and thrive. But take it even one step further. Say, I am worth it. And I'm going to prioritize my sleep, because sleep is that free prescription of goodness, of health, of peace, of calm. And then here are some practical tips. If you love coffee like I do, I admit it, I enjoy it, stop drinking coffee after the morning. Drink it in the morning if you need to. Alcohol is going to interfere. It may seem like knocking back a couple of beers after a stressful day is calming you. It's not. Alcohol is a depressant. It's a serious depressant. So don't drink caffeine after noon to 2 o'clock, maybe. Don't drink alcohol. Start to be conscious of your thoughts. If you're going to exercise, that is excellent for your sleep, but try not to do it right before bedtime. Look at your bedroom. Throw out the TV, throw out the devices. Make sure you have curtains and drapes that give you a nice dark room. If the temperature is anything above 68 degrees, bring it down. A cooler temperature is going to be better. Buy yourself a gorgeous, gorgeous diary. Get a beautiful pen. Write down what you're feeling. Have a ritual. Create a ritual. The sky is the limit. If you love candles, be very safe. Get a candle. If you love classical music, whatever it is that's going to help you, turn off the devices, aromatherapy. All of these things have a place in us being friends with sleep. Consistent bedtimes are the top of the list. If you can, within reason, we're all human, we have things that happen. Nobody has a mechanical schedule, but again, go back to what I said, prioritize your sleep. Make an opportunity for you to sleep as an adult, 7 to 8 hours. Things happen. One night you may have something a little more going on, but at least give yourself the opportunity by turning down the rest of the world, turning it off, and giving yourself the opportunity. If you're snoring, if your partner's, shoving you all day long, if you're waking up unrefreshed, you have headaches, talk to your primary care physician or look up a sleep center in your area, call for a consultation. Go in, discuss your sleep issues, and see what that sleep physician has. They may say, hey, this is not something of concern, 1, 2, and 3. Or they may say, we need to do a sleep test. Review your medical history with yourself. If you're taking a lot of medications for hypertension, for depression, for other psychiatric disorders, you have had a history of stroke, you have diabetes, you have regurgitation, all of those things may be an indication that there's a sleep disorder as well. So think of all of those things, prioritize sleep, create an environment for an opportunity to get good, peaceful sleep. Pay attention to your needs. Put yourself first. Someone may not like the fact that you don't answer the phone after 9 o'clock at night. Well, you're going to have to set boundaries. And Kristin, going back to the same thing, so many times we think we're being really nice, we're being a nice person, but in that we even give up our sleep because we're on our emails and we're trying to get back to people. But we have to stand up and say, my health and well-being is of priority. And when I'm better, I'm actually more engaged with you. So I have to sleep. These are the things that, as someone who's struggling to sleep, you can do tonight, but do them one step at a time. If there's one thing to pick, a consistent bedtime, caffeine, alcohol, not before bed, and journaling. Express yourself. We keep things locked up here. We keep them locked up here. We carry them to bed. And just know that the mysteries of sleep, we're just starting to decode some of them. So go by what the poets said. Go to bed and in the morning you'll feel better. Try it, but prioritize it. You gotta put sleep at the top of the list. And those are the things that you can do starting today.
But any questions so far or comments? It's a lot to take in.
Dr. Merriman,
Yes.
The way some people can have micro sleeps during the day and they might enter into, I've often talked to medics who on a long shift will have kind of brief periods of sleep paralysis where they could be sitting in the seat, they go to sleep and they suddenly have either a traumatic memory reoccur or be asleep but also awake. Is that ever discussed with your clients?
That would be outside of the scope of my sleep practice. And for that, again, I would do exactly what you would do, is refer them back to the sleep specialist who has a much broader scope of treating and recognizing and diagnosing sleep disorders. So again, it's about collaboration. So if you can have a psychiatrist who is a sleep specialist, that would be a great referral. And it sounds a little bit like narcolepsy. It sounds a little bit like flashbacks. There's a lot of patients who have trauma that do have circadian rhythm disorders, and they do get flashbacks, and it could be nightmares as well.
Good. Thank you.
Wonderful. And we do have one question that has come up, and it's whether or not a person can, let's see here, access REM sleep through a meditative state, through meditation.
Well, meditation has a variety of benefits, and better sleep is definitely there. Again, I would not be the person to comment on that. However, good sleep hygiene, which is having a ritual, cutting out caffeine and alcohol, keeping the temperature of your room around 68 or so, but also expressive writing, which is a form of meditation where we're taking out what is troubling us here and putting it on paper, is a meditative way. And it has shown through research benefits of better sleep. So I recommend all of these measures to my patients to do.
Dr. Merriman, and we thank you. I mean, you are here and you're sharing your knowledge and your spirit and your love. And you're just reaching out to so many people who are going to be sleeping better and feeling better and be more able to move into themselves so that they can also be there for others. But as you know, it starts with being there for ourselves first.
That's it. Starts there. It starts there.
I'm going to open up to questions, but I want you to know that, you know, in my offices, what people hear all the time is self-love, self-care, self-compassion, over and over and over and over again. So does anyone have any questions for Dr. Merriman?
I do. Thank you for that presentation. It's wonderful. One of the biggest things that comes up with the clients, and mostly all of my clients are veterans, and one of the first questions I ask is, how's your sleep? And almost always that's at the top of the list for why they're going to do the treatment that they're going to do, is to get clarity and to get, around why they don't sleep, or just to heal whatever is blocking them from getting good sleep.
Insomnia is a symptom. It's not a sleep disorder per se, but insomnia is considered when a person cannot fall asleep or stay asleep when given the opportunity, when they have the opportunity to sleep, or both. They have difficulty falling asleep and staying asleep. Now, a lot of times you're going to find a history of a patient either taking over-the-counter sleep aids or being prescribed, like my patient was, for something, a sleep aid for years without reevaluation. That is a cause for concern. That I'm very comfortable stating, because when my patients come in, even if I'm treating them for obstructive sleep apnea, if they've got a long time history of sleep aids, I will send them back to their sleep physician. Cbti, which is cognitive behavior therapy for insomnia, has now been proven to be the #1 successful treatment for insomnia, and it has long-term effects. So not only are patients who go in and get CBTI at that time improving their sleep, but those benefits that they gain remain with them for quite some time, if not indefinitely. So that's something that, Moose, I would strongly encourage to look within your community. And Kristin, you may know someone, or you may even want to be certified as someone who does CBTI. There is a huge shortage of such professionals. Now we're doing a lot of it, not me being a CBTI, I have thought about going in for certification, but therapists are doing it through Zoom. And it's about 8 to maybe 10 or 12 sessions. It's a contained amount of very specific therapy that is focused on getting the patient to record their sleep patterns, to talk about their anxiety with sleep deprivation, because it becomes a circle. I didn't sleep well today, so now come dusk, I'm stressed that I'm not going to sleep well again. I'm already tired from being sleep deprived from last night. How do I know so much? Because I went through all of this. So then it becomes an overriding concern that now if I'm someone who ruminates, now I'm ruminating about my poor sleep. So CBTI is an excellent way of addressing that. On top of that, the numbers are like 60 to high 60% of success with these patients. So medication and over-the-counter, it's warranted in some places. In some patients, they may have an acute episode of sleep deprivation or what's going on, or their mental health right now is in an acute phase of activity. So I'm not saying or stating that medication for insomnia is not necessary and indicated. What I'm saying is that it is over prescription of medication for patients who suffer, individuals who suffer from insomnia, that I'm commenting on. And for them, CBTI may be a great thing. You might be able to direct your patients to seeking that source or partnering with someone who does CBTI and is going to work with your patients, the veterans who are possibly having, much more difficulty with insomnia than your other clients. I think it's a terrific idea if therapists can invest and find that time in their practice, but even better, maybe just someone who does CBTI all the time and then just collaborate with that person.
Is there anything else that you would like to share with us?
If we could just open ourselves up a little more, and we'll see how beautiful things become, because we are connected and we're living in a time of lovelessness, and we have to change that. We're here, yes, we have skills, someone's a therapist, someone's, doing dental sleep medicine, but we're here in the service of love. I'm here in the service of love. That's what we are here for. By bringing love out and the skills that we have, we are looking to heal ourselves and heal others, because we are connected, and this connection has to be brought back in the vibrancy and the splendor that it has. We are here for love.
Because you have come here and shared what you know. And I think tonight, some people are going to be sleeping a little bit easier. So thank you very, very much, Dr. Merriman.